If you're a medical trainee, you see the fallout from cardiovascular disease every single day. But going from just knowing the facts to having a real solid framework for patient risk, that's a big jump. So in the next few minutes, we're going to build that framework together. Something clear, something you can actually use on the wards tomorrow. Let's dive in. I want to start with just a number, 31%. Seems kind of abstract, right? But this one figure, it represents one of the single biggest challenges we face in medicine today. And there it is. That's what 31% means. Nearly 1 out of every 3 deaths in the US was from cardiovascular disease. I mean, even with all our modern advances, it's still the #1 killer. That's why our ability to spot and manage risk is, well, absolutely critical. So here's our game plan. First, we'll really get a handle on just how massive this problem is. Then, we'll build our core framework with what I call the big 5 risks. After that, we'll add in some crucial details. Then we'll figure out how to turn all those factors into an actual risk forecast. And finally, we'll talk about how to fine-tune our approach for every unique patient we see. To really understand why this framework is so important, you've got to see the numbers first. And these aren't just statistics on a page, right? They represent the real people walking into our clinics and hospitals every single day. Just look at this. It shows you just how widespread CVD is. Think about it. Nearly half of all adults over 20 have some form of it. And yeah, that includes high blood pressure. But here's the real kicker. Look at how it explodes with age. It jumps to over 3/4 of people between 60 and 79. This isn't some rare disease. It's a nearly universal part of aging in our world. And that massive prevalence, it comes with a truly massive price tag. In a single year, the total cost of CVD in the US was estimated at $350 billion. A number that big tells you we're not just fighting a clinical battle, but a huge societal and economic one too. Okay, so with that context, let's get practical. Let's build a framework you can use right at the bedside. We're going to call it the Big 5. These are the core modifiable risk factors that have to be on your radar for every patient. And here they are. Seriously, think of this as your primary checklist. Hypertension, dyslipidemia, diabetes, tobacco use, and obesity or metabolic syndrome. If you master these 5, you have the foundation for almost any cardiovascular risk assessment. First up, hypertension. Using the current threshold of 130/80, this chart shows us that nearly half, 46%, of all adults have high blood pressure. And since it's so often silent, this number makes it crystal clear why we have to be screening for it all the time. Next, dyslipidemia, abnormal cholesterol. Even a simple total cholesterol check can give us a quick and dirty look at risk. 12% of adults have levels over 240. That's a huge number of people dealing with atherosclerosis, which is basically the process of plaque slowly hardening up their arteries. And then we have diabetes. Honestly, this statistic is chilling. A diabetes diagnosis isn't just about blood sugar. It is a profound cardiovascular risk factor. The fact that 68% of people with diabetes will eventually die from heart disease, it tells us we have to treat it like it's already a cardiovascular disease. What about tobacco? Well, the good news is the body is amazing and it wants to heal. The second a patient quits, their risk starts to drop. But it's a long road back. It can take more than 15 years for their risk to get close to someone who never smoked. This is such a powerful tool for counseling. It shows there are immediate benefits, but it also reinforces that this is a long-term commitment. Finally, let's talk about obesity and its partner in crime, metabolic syndrome. It's not just about weight, it's about a dangerous cluster of problems. When your patient has 3 or more of these 5 things, like extra weight around the middle, high blood pressure, and high blood sugar, they have metabolic syndrome. And the key takeaway is that this combination of factors just sends their cardiovascular risk through the roof. So, the big 5 are our foundation, but a really sharp clinician knows you have to dig deeper. So let's go beyond that core list and talk about other critical factors that can totally change a patient's risk profile. This is where we add the next layer. A family history of early heart disease, that's not just a footnote, it can literally double a person's risk. Things like depression and anxiety aren't separate from physical health. They're directly linked to worse heart outcomes. And always remember, chronic inflammation, whether it's from kidney disease, an autoimmune condition like rheumatoid arthritis, or even HIV, is like a constant stress test on the whole vascular system, and it speeds up risk. All right, so we've gathered all this information. We have our list of risk factors. Now what? How do we put it all together? This section is all about going from a simple problem list to actually forecasting a patient's future risk. This is the million-dollar question in clinic. isn't it? Is the patient's hypertension more worrisome than their family history? How does their cholesterol stack up against the fact that they smoke? To answer that, we need objective tools. And this table really shows how our tools have evolved. We started with the classic Framingham score. Then we got smarter, adding things like family history and inflammation with the Reynolds score. Then we figured out how to use imaging with the MESA score. And all of that progress has led us to our current gold standard, the ACC/AHA Pooled Cohort Equations, or PCE. For most of your patients here in the US, the pooled cohort equations are going to be your go-to. It's built on data from really diverse groups of people, and it's what the major guidelines recommend for estimating that crucial 10-year risk. This is the tool that helps you decide things like, hey, is it time to start a statin? But, and this is a huge but, no calculator is a crystal ball, and no two patients are ever the same. So for our last section, we have to talk about the critical nuances of risk, especially when it comes to equity and specific groups of patients. Let's talk about sex differences. While chest pain is common for everyone, women are much more likely to show up with those atypical symptoms. What's more, risk factors like smoking and diabetes seem to pack an even bigger punch in women. And tragically, women have a higher mortality rate in that first year after a heart attack. We have to keep these differences top of mind. Now for a really crucial and evolving conversation. Our best tool, the PCE, uses race as one of its inputs. But as the source material points out, that's problematic. Race is a social construct, not a biological one, and using it can hide the real drivers of risk, like systemic inequities. That's why the entire field is moving towards new race-free models like PREVENT. You're going to be hearing a lot more about these soon. And this really brings us back to the ultimate goal. We have these tools for a reason. Our job is to use them to get ahead of the game, to find that high-risk patient before a catastrophic event happens, so we can step in with lifestyle changes or medicines that can literally change their future. So, I'll leave you with this question to take into your next clinic day. For your very next patient, what's one of those risk-enhancing factors we talked about? Maybe it's their family history, an inflammatory disease, or a psychosocial stressor that you'll now make a point to ask about. Because that's how we move from just good care to truly great care.